So good morning. Good morning to everyone who's attending here today. I'm Eva Turbiner. I am the President and Chief Executive Officer of Zufall Health. And on behalf of our health center, I want to welcome all of you to our 4th annual Rural Oral Health Conference. And this year, the conference is focused on diversity and inclusion, and in particular, addressing the needs of marginalized populations in our rural communities. As many of you know, this conference started out as an in-person conference several years ago. And unfortunately, because of the pandemic, we were forced to shift to a virtual format. But frankly, it has proven to be really a silver lining of the pandemic, because this virtual format, as you'll see today, has allowed us to recruit nationally renowned speakers, a really wonderful group of folks. And we've also been able to have attendees from all across the United States. I believe that we have more than 300 people who will be participating in the conference today. And Zufall Health is really proud to host this event as part of the national recognition of National Rural Health Day, which was celebrated yesterday on November 17th. So it's my job to thank our partners and sponsors for this conference. And first, I want to acknowledge the partners that we've worked with so closely in preparing this event. And that includes the New Jersey Department of Health. Dr. Omolola Taiwo, Damon Koslow, and Marisol Meyer are joining us here today, as well as our partners from the American Dental Association, which includes Dr. Jane Grover and Kelly Cantor, and from HRSA, Zufall's federal funder, and we have Dr. Tanya Pagan Raggio, who is joining us today. And I also want to especially thank our platinum sponsor, CareQuest Institute for Oral Health. And that organization is a leader and champion of oral health and the issues surrounding health equity for all. I also want to thank our other sponsors whose support today has made this conference possible. And that includes Aetna Better Health, BD, Benco Dental, Delta Dental, Finger Paint, Fulton Bank, Horizon Blue Cross Blue Shield, LabCorp, Liberty Dental, United Healthcare, and Valley Bank. And we're so grateful to all of these organizations who helped us do a really wonderful event. And I hope all of you will really enjoy. And last but certainly not least, I want to thank Dr. Sam Joachim, Zufall Health's Chief Dental Officer, the planning committee for this conference, and certainly our team from Zufall Health who worked for months to prepare the speakers that you're about to hear. We hope that you're going to be engaged in the sessions, ask lots of questions. You will get instructions on how to ask questions and put things in the chat. And I hope you're going to come away with new ideas and approaches about the issues that we will be addressing today. So thank you very much. And I believe that Dr. Joachim is next up on the agenda.
Thank you so much, Eva. Thank you, and good morning, everyone, and welcome for. Thank you for being here, and welcome to the 4th annual Rural Oral Health Conference. Miriam's going to share some slides. That we find this as a great opportunity for us to learn from each other and teach each other. And we have over 300 participants today joining from 45 different states, with the top states being New Jersey, California, Pennsylvania, Texas, and Maine. And we have a number of countries represented on today's conference, including folks from Canada, Ireland, India, and Pakistan. So we definitely want to thank you for choosing to spend your day with us, whether you're planning to be here for the whole day or part of the day. We're grateful that you chose to do that today. So before we get started, I wanted to kind of ask you a question. And on the next slide, I would love to hear you guys in the chat to see if you could chat in what diversity, equity, and inclusion means to you. And if you could share some examples from your work, your workplace, or your environment, or any thoughts that you have on diversity, equity, and inclusion in rural oral health. I wanted to start by sharing some examples. There are many examples, but I wanted to share some in our work setting. And so we have a residency program, and our dental residency director has noticed that when we have residents coming in from different schools, different backgrounds, they seem to strengthen each other. When we, by the end of the year, we find that they not only have strengthened the program, but the quality of dentistry is so much better when people come in from diverse backgrounds, diverse schools, and learn from each other. So this is something that companies all over the country and the world are also finding out. And it is something that researchers are finding out as well. An example of equity. So for us at Zufall, we've been proud to participate in the National Network of Oral Health Access Collaboratives and in the CareQuest Institute Collaboratives. And from that, we really learned the importance of caries risk assessments and being able to identify high-risk patients and provide them with on-time, frequent disease management visits to decrease their risk for new decay. And we've been fortunate to see the outcome of having fewer decay, less caries on recall in those patients. So that really encapsulates equity, oral health equity for us. Examples of inclusion at Zufall include things like having a lactation room that sometimes doubles as a prayer room for those who need it, having a single unisex bathroom for those who need it, and of course, opportunities for working from home or medical and dental visits for those who need those services as well. So please share with us, would love to hear your examples in your workplace and some of the fantastic work that you do. On the next slide, I wanted to share briefly what's on the agenda for today. So we're building on some of the work that we did last year. We have some fantastic plenary sessions, and we have a number of great breakout sessions for you to choose from today, including a session on food insecurity with Dr. Jane Grover and Dr. Tanya Cook, among others. We have a session on spirituality and oral health that will be moderated by Dr. Pagan Rajio Ashley. And we have a session on caring for special needs patients, among many other sessions. And at the end, we'd love to hear from you. What have you learned? We'll reconnect at the wrap-up session with Dr. Marsha Brand to talk about what you heard, what will be your first action step leaving here today. We'd love to hear your thoughts. And because we know there's a lot of pockets of need and a lot of pockets of special populations all over rural areas, we'd like to hear, what might we have missed, and what else would you like to hear about in future conferences? So with that, I would like to turn it over to the Rural Health Project Officer for New Jersey at the Office of Primary Care and Rural Health, my colleague, Marisol Myers, who will get us started.
Good morning. Thank you, Dr. Joaquim. My name is Marisol Meyer. I'm the Rural Health Project Officer at the Office of Primary Care and Rural Health. On behalf of the New Jersey Department of Health, I would like to thank all of you for your participation in the 4th Annual Rural Oral Health Conference. I'll be introducing all the presenters throughout the day, so please refer to the conference program for all the presenters' bios. Before we start, I would like to remind you a few housekeeping items. Attendees are muted, but I can raise their hands or type in the chat. To ask the speaker a question, please use the Q&A window. Questions will be addressed at the end of the presentation if time allows. To receive continuing education credit for this session, please complete the survey shared in the chat. Surveys links will also be mailed to all attendees. And when the session ends, attendees will be automatically routed back to the lobby to choose their next session. So I would like to introduce our keynote speaker, Dr. Deborah Brown, Chief Executive Officer at My Community Dental Centers. Dr. Brown will talk about diversity and the impact on oral health, a personal journey. After these sessions, attendees will be able to explore aspects of diversity and formulate a personal understanding of diversity and inclusion, identify barriers to a diverse organizations and way to overcome these barriers, and discuss opportunities to facilitate diversity within their own organizations. So I will pass it on to Dr. Brown.
Thank you, Marisol, and good morning, everyone. Wow, I heard there are about 300 participants today, and it's my pleasure to be given this opportunity to spend some time with you. I'd like to thank my dear friend, Dr. Sam Joachim, for inviting me to be the keynote speaker for this 4th annual Rural Oral Health Conference. You guys have a great day planned with some awesome speakers, and I'm sure it's going to be a great time of learning for everyone. Again, it's really an honor to speak about my own personal experiences with diversity and share some of my stories with you. I'm a native of New Jersey, and I know there are a lot of people from New Jersey on here, so it feels like a bit of a virtual homecoming as I speak to you from the Midwest, where I relocated. People always ask me, do I miss New Jersey? And of course I do, because I've never lived anywhere else except for my time in the military. And we're having some snowy weather today. So wherever you are today, I hope that you're having better weather. I just want to go into a little bit about myself. I'm a general dentist by training, and I've been on the administrative side of dentistry for approximately the last 10 years. As I said before, I relocated to Michigan for my current position as CEO of my community dental centers. And I'll tell you a bit more about the organization in just a few minutes. The opening slide that you're looking at, it represents many people, different colors, careers, abilities, sizes, big, small, gay, straight, old, young. I mean, I could go on and on about what diversity means to me. But the point of this first slide is to show that there are many faces of diversity and equity and inclusion. My presentation to you today is really about giving you my perspective through a collection of some short stories that span throughout my life and my experiences. I want to be able to paint a picture for you of travels through my life and how diversity impacted me. My family has always considered me a storyteller and a historian in the family, so hopefully you're going to enjoy this talk, and as you listen, maybe you'll see some similarities to your own life, or it might spark a new way of thinking about diversity for you. So, next slide, please. So as Marisol said, we have 3 objectives. First, I hope that you will all come away with the ability to explore aspects of diversity and formulate your own personal understanding of what diversity and inclusion means to you. Secondly, you should be able to identify barriers to a diverse organization and ways to overcome them. And third, you should be able to discuss opportunities to facilitate diversity in your own organizations. Later in the discussion, I'll talk about a few of the barriers that I've personally seen in the workplace, and then some of the ways that we've made changes at MCDC. In full disclosure, I just want to let you know that I don't have formal training in diversity, equity, and inclusion, but these are my personal experiences that I want to share with you today. Next slide, please. So first, I'd just like to give you a little background on the organization that I currently lead, because I think it's a really important part of my story up to this point. My community dental center started in 2006 in Northern Michigan with 8 dental centers. They partnered with local health departments, and we're seeing at that time approximately 35,000 patients a year, unique patients. We've now grown to over 34 centers and serving approximately 90,000 patients per year across the entire state of Michigan. We're known in the local community as MCDC, and we are a nonprofit dental organization. We're dedicated to serving communities that have very limited access to quality oral health care. Our patient population is 85% Medicaid, and this includes children and adults. We also self-fund our own sliding scale fee schedule for patients that don't have insurance. Currently, we're the largest nonprofit safety net dental provider in Michigan, and many of the locations that you see on this slide are located in rural areas where it's very hard to recruit for doctors and staff. In particular, the upper part of the slide is the Upper Peninsula of Michigan, or also known as the UP, and it's very rural. We actually have 3 centers in the UP. One of them was on the verge of closing because we couldn't find a dentist, but luckily we were able to hire someone just before we put the closing into motion. Dentists in the UP that are retiring, they're having a difficult time finding buyers for their practices, or some are just closing down their offices, and this has caused an access to care issue in that region of the state. This is why I believe it's so important to recruit dental students from these rural areas that will hopefully want to return home and practice there. We were lucky last year to recruit a new graduate dentist that went to dental school in Detroit, but he grew up in Marquette in the Upper Peninsula. So he's just completed his first year with us. He's doing great, and he's been able to help create more access for patients in that dental center in Marquette. Next slide, please. At the end of state fiscal year 21, we saw over 85,000 unique patients, with almost 68,000 of them having some type of state-funded dental coverage. HKD is our Healthy Kids Dental for the state's children's program. HMP is Healthy Michigan Plan, which is the adult Medicaid expansion program. And we also have the traditional adult Medicaid fee-for-service that's administered by the state of Michigan. This slide just represents the breakdown of the various populations we serve, but I'd like to note that even with our statewide presence at MCDC, along with our FQHC partners, many people in Michigan, especially adults, seniors, and veterans, still have a struggle accessing basic dental care. Next slide. So in thinking about how I viewed diversity in the past, I really only thought about diversity as it relates to race, religion, gender, ethnicity. So I had it in this little bubble. But I now know that diversity is much more than that. Besides being an African-American female, who I am is made up of so much more. So who is Deborah? Well, I have some of the categories that can describe me displayed on this slide. I'm a female veteran, a gay woman, a public health dentist. I'm over the age of 50. All of these things make me the person that I am and allow me to contribute in different ways and from different perspectives. One that's not on this slide is the fact that I'm no longer an everyday chairside dentist anymore. I'm most of the time in administration. So that particular role also offers its own unique perspective and can bring a different perspective to the table. I'm happy to see that in organized dentistry, an effort is being made into being more inclusive, especially in terms of outreach for membership, not only for racial and ethnic minorities or gender classes, but for non-traditional roles such as group practice dentists, DSO dentists, academia, and new dentists. Each of these practice modalities have different needs when it comes to membership. I'm proud to be a participant in organized dentistry at all levels, and I can say that I really see that things are moving forward. Next slide, please. So this slide only has a few pictures, and that's intentional, doesn't have any words. I did this on purpose because I want to focus more on the storytelling here. What this slide shows are pictures of the neighborhood that I grew up in. I was born and raised in Paterson, New Jersey, which is a very urban, inner city, quote unquote, hood. So that's an actual picture of the house that I grew up in. And the neighborhood hasn't really changed much since I lived there, except it's a little more crowded, a lot more cars and people. But when I reflect back as a child, I honestly didn't realize I was living in the hood. And maybe that's a good thing. Seeing crime, drugs, and prostitution was pretty normal in my neighborhood. There was a street fight, a house fire, a burglary every week. Under these conditions, you can imagine regular health care was scarce and oral health care was a luxury, not a priority. My parents, along with most parents in my neighborhood, they were focusing on paying the bills, keeping you off the streets. They tried to shield us as much as possible from what was going on right outside of our door. But every now and then, we saw things that most kids shouldn't see growing up. Both of my parents, they lost their teeth at a very early age, and I honestly can't remember them talking about the importance of brushing or what would happen to my teeth if I didn't brush. My sister and I, we were allowed to eat a lot of sweets and drink a lot of sugary drinks. I don't think they did this out of negligence. I think it was just the opposite, really. I think they wanted to give us the things that when they were kids, maybe their parents weren't able to give them. So by giving us treats, they thought it was a good thing. My parents, they grew up in the South during the era of segregation and Jim Crow. They only went to a dentist if they had pain. And then the treatment, as you could guess, was usually extraction. So they both ended up early in dentures, and that was very common at the time. With our parents being our first teachers, they passed down to us what they know about oral hygiene, dental health, and overall health. So the expectation when they were growing up is that most people are going to lose their teeth and end up wearing dentures anyway. So as I was growing up, information was getting better surrounding the importance of oral health, but it still wasn't like it is today. I think they did better with us than their parents did with them, but I never remember receiving fluoride or sealants or being a part of the programs that they have now, the sealant programs and fluoride rinse programs. They really play an important role in caries prevention and education. There were no oral health advocates coming to the public schools in Paterson at the time. And I don't remember anyone coming into our Head Start, except for one time, there was a public health dentist who did come in to the Head Start and do exams for us. I can remember it being a very scary experience because even at the age of 5, I had not yet seen a dentist. And I definitely had not seen a dentist or a physician that looked like me. So the sweets and the sugary drinks, they eventually caught up with me. And I went to my first real dental visit. I can still remember that visit because the dentist was African-American, and it was my first time seeing any doctor that looked like me. But not only that, I still remember the sounds, that familiar smell of the dental office and the instruments he used. I actually ended up that day having 12 cavities and having to go back 3 to 4 times to get multiple fillings and lots of those beautiful stainless steel crowns. But the true takeaway from this story is that experience left a very positive impact on me. Even as a 5-year-old, this man in his white coat, he looked like me. He was nice to me. He took away my pain. Most important, he gave me a toy for being good, and he looked like me. Years later, when I was deciding on a career choice, I look back on my visits with Dr. Haddon. He remained the only African-American dentist I ever met until I entered dental school. Representation matters, and it's important for advancing oral health in vulnerable and underserved communities. It builds trust and allows a young child to see themselves in that role. I'd like to think that that experience had a very positive impact on my decision to enter dentistry. Next slide, please. So I'd like to take you a little bit forward in my life into my military time and just talk a little bit about how diversity was or was not reflected in my experience, and talk about some of the oral health impacts. First, some background on how I landed in the Army. Well, by my senior year of high school, I have to say I was pretty fed up with school. I never was one who liked school when I was younger. I did not have any aspirations for college, and I often hung out with the wrong crowd. My crowning glory was taking the family car at 16 years of age into New York City, filled with a group of teenagers to hang out at the pier in the Village. Well, you can imagine how that ended up with my mom and dad. My mom always said, either you go to college, you get a job, or you go in the military. Well, having no real skill set, I didn't want to work fast food. I didn't want to work in a factory. Ironically, I thought I was above doing that kind of job. So I said, okay, I'm going to go join the Army. Now, I don't know what I thought it was going to be like. And thinking back to my 18-year-old self, I think I thought it was going to be full independence, no one to answer to. But what a surprise I got when I stepped off the bus in Fort Jackson, South Carolina. Needless to say, it wasn't what I had imagined at all. The year was 1984. I had just graduated from high school, and for those of you old enough to remember 1984, Purple Rain was the popular movie at the time. Women were increasing in numbers within the military, and the military was becoming more diverse, and they were intentionally recruiting for more women and minorities. I often saw recruiters at my high school. They would come into the neighborhood where we would hang out at the park or at the basketball court. And while that was a good thing, when I look back, they failed to really educate how increasing the integration of women in particular would be received, and to educate all soldiers about acceptable and unacceptable behaviors. At that time, men and women were beginning to be housed in the same barracks on the same floors. And within my unit at that time, there were some multiple allegations of harassment. Other female soldiers and I were subjected to uncomfortable situations by fellow male soldiers and superiors. Most often, our superiors were male, because not many women at the time were in leadership positions in the military. So a very short story of my own experience is one time I was working alone with a male soldier one day, and he touched me inappropriately. Well, I tried telling a female superior and was told to just let it go because no one would believe me and it wasn't worth making a complaint. Well, she was one of the only African-American women in military leadership in my unit, and she didn't really want to take up the risk of defending me. And I understand why, because she was standing alone herself. So nothing was done. But for every story like mine, imagine how many more there were. And for me, that's why representation really matters. So we can advocate for each other and be allies together. Worse yet was being a part of the LGBTQ community at that time and being a soldier. Don't ask, don't tell didn't exist. And you could actually be dishonorably discharged for being gay. I can remember being at a nightclub one night, and as we were leaving, the military police were posted outside of the club looking to arrest military members that were from their unit. Luckily, I was from an out-of-town unit and able to leave without incident. But it's something I'll never forget. It was the fear of being outed. For me, all of this is relevant because the way we think about oral health or overall health and the ability to access care is a reflection of our own personal experiences. Having providers that can relate to your experiences, your identities, and communities helps to build better bridges so that we have better care and better outcomes. Next slide, please. It took a long time for me to be proud of who I was and who I am, not only as an African-American, but just feeling as if I fit into society as a gay person. The 80s were a great time for me and a lot of Generation Xers. The music, the clothes, the big hair. But in the midst of the fun, there was also a lot of homophobia during my coming of age, due in some part to the emergence of HIV and AIDS. I was still in the military during that time, and I was also coming to terms with my own orientation. There was a huge stigma surrounding gay men and how HIV was transmitted. I can remember some of my former high school friends, and they became HIV positive. They were shunned by their families, their friends. People didn't want to hug or touch them. Their own families gave them separate dishes to eat from out of fear of catching it from them. At the time, I'm sure there were people in leadership, in organizations, in the military that were probably part of the LGBTQ community, but I wasn't certain. So how do you find friends or how do you find allies? Being open and letting someone know at that time, that was out of the question. In the military, you feared being discharged. And in the civilian world, you feared losing your job or even losing a good friend. I can remember agonizing over whether to let a friend know that I was gay. Fortunately, it was a positive outcome. And 20 plus years later, we're still friends. It's difficult when you can't share your authentic self with people, especially someone that you consider a friend. Back then, you also had to be concerned about violence or attacks. I wish I could say that no longer exists. It has gotten better, but violence against the LGBTQ community still exists. There's still a lot of work to do in fostering an environment where employees, patients, and all of us can be our true selves. Next slide, please. So how did I end up as a dentist? Well, I took a non-traditional path towards dentistry. After being honorably discharged from the Army, I still wasn't sold on this idea of going to college. I worked at multiple different jobs trying to find myself. This went on for 5 years until I was laid off, and then I couldn't find another job for months. I then decided, well, maybe I'll give this college thing a try. So at the age of 27, I entered Rutgers as a freshman. I started dental school 4 years later and graduated from dental school at the age of 35. I made the decision on dentistry after shadowing several dentists and also seeing the underrepresentation of Black and Brown people in the profession. I've been lucky to experience working in different types of practice environments. I've worked in private practice, group practice, FQHC, mobile dentistry, and administration. As I mentioned earlier in the presentation, I came to realize that diversity means so much more than the traditional categories we think of. All of the different practice modalities really have a role to play. Having the different voices at the table makes a difference in how decisions are made. For example, in Michigan, adult Medicaid restructure is now a reality due to the diverse voices of many organizations that came together, like the Association of Health Plans, the Primary Care Association, the Dental Association, MCDC, and many others. Having those diverse voices has resulted in a win for Michiganders that are served by Medicaid. Next slide, please. In my experiences at different organizations, I've observed some barriers to creating more diversity in the work environment. One thing I notice is that intentionality is often missing. We need to be more intentional in our hiring practices and recruitment. Creating practices that actually reflect the communities that we serve. One of the first things I did when I was thinking about applying to my current position is I Googled the organization. I took a look at their website and locations of their centers, and I would guess that many applicants do the same thing. I will admit I wasn't sure how diverse the organization was, but I decided to go for it. And I'm glad I did. Maybe I can be that person who becomes an example for someone else. Maybe they will look at me and see themselves. Last year, we had a hygienist apply for a job. She had a peripheral vision deficit. She needed an accommodation because she uses a guide dog to get around. We were very intentional about doing research to find out how we could best accommodate her and be able to integrate the dog into the dental center environment. We had her bring the dog in before her start date and get to know the office and staff. She educated the staff on her vision deficit. She took questions. She really became an example to other people like her. Without intentionality, things often remain as they are, and we miss out on the advantage and richness of diverse experiences and points of view. We hear the word diversity a lot these days, and it's really good to see more education around it in the workplace and in oral health. There are efforts across the country to attract more minorities to the field of dentistry. I've also heard many things about educational programs that go into middle schools and talk to the students about careers in dentistry. The Michigan Dental Association has a diversity, equity, and inclusion committee, and implicit bias training is now a required course for all licensees in the state. We also see many large organizations that actually have a diversity, equity, and inclusion executive. So change is happening. In addition to education, I think we need to be more open to having the difficult conversations. We need to be comfortable with being a little bit uncomfortable. I was a panelist on a diversity discussion that went really well. People were engaged, respectful to one another, asking questions and making comments. I felt like all sides really wanted to learn and were open with having the conversation. In contrast to that, I took my required implicit bias course, and the participants were very combative about the information being presented, placing inappropriate comments in the virtual feed, and just not open to having the conversation. In my opinion, it was unfortunate because these kinds of barriers are just holding us back. Next slide, please. So at MCDC, we have started taking more steps towards promoting diversity. We currently give all employees a paid diversity, equity, and inclusion day. They're allowed to pick a day related to their religion, social belief, patriotic belief, etc. It's a very expansive list. Some employees choose a day in June for Pride Month or MLK Day, Diwali, Eid. Some have even chosen Arbor Day. So it's really to their discretion. The importance of it is that they're able to choose the day that celebrates their idea of diversity. On our social media pages, we celebrate diversity by acknowledging and celebrating cultural holidays. We try to use diverse and inclusive imaging in our print and electronic media. We also created an organizational video that highlights diversity, which I'll share with you at the end of the presentation. I'm happy to say we now offer employees the ability to place pronouns in their signature lines. We were a little bit late to that party, but it seems like it is a welcomed addition. A suggestion that we have from the field is that we add patient pronouns to registration forms. One of our doctors made this suggestion because he had a patient and wasn't sure how to address them, but he wanted to be able to say the right thing. So now we're looking into how we can add this with our electronic dental record provider. Another patient-centered effort we've implemented is the use of community health workers and community dental health coordinators to engage with patients by helping them to navigate oral health and community services. Many veterans don't qualify for VA dental services, and we were seeing that our veterans were having difficulty accessing oral health care due to the financial constraints. I also experienced how difficult it is. When I left the military, I assumed that the VA would provide me with dental care. One day I had a bad toothache, went to the VA hospital only to find out I didn't qualify. Not having dental insurance and unable to afford private practice fees, I went to the emergency department where I received antibiotics and pain meds, but at least they were able to direct me to an FQHC, and that's where I was finally able to be seen for my pain. At MCDC, after offering a day of care for several years on Veterans Day, we decided to create a veterans fee schedule for those without insurance. We also partner with the County Veterans Organization, and they give us a grant to cover services for vets in their county. My goal for 2023 is to be even more intentional about diversity, equity, and inclusion, and trying to make sure we have representation from all of our community, not only at the employee level, but the patient level also. Next slide, please. So to pull this all together and summarize, I can say that we at MCDC have seen how diversity has made our organization stronger. We know there's still work to do, and we'll be working on hiring practices that support diversity, equity, and inclusion. I hope that my story turns on some light bulbs or just gives you a different perspective about diversity and the various aspects that you may not have thought about. But if you don't remember anything else from our time together, I would ask that you remember to keep an open mind and be comfortable with being uncomfortable so that we can continue to move the conversation forward. Next slide, please. So, as promised, I'd just like to share with you, it's a 3-minute video that was created shortly after we returned back to work from the pandemic. It was created for our annual report, and we wanted to show our partners that we've come back resilient, strong, and diverse. So we'll play the video for you now. I'm not sure we're getting any sound to the text.
And up.
High risk of spreading COVID-19 and nationwide closures of many dental practices places oral health at the wayside.
In 2021, we served over 85,000 unique patients and provided over 190,000 office visits. Of those office visits, we completed 7,700 same-day emergency visits, and we did all of this while maintaining a 4.9 star rating from our patients.
Our organization is fortunate to have dedicated staff that work so well together.
This organization, I feel so much passion for each and every individual that I have come across in this organization.
I did a complete denture for her. When we delivered it, she just started bawling and stood up and gave me a hug and said, "You changed my life." And I actually felt like I did.
This was amazing. They texted me yesterday and said we have a program, and here I am, yay. It is awesome, and I appreciate it.
Our patient reviews affirm that our talented and dedicated team members are committed to providing dental care to all. with compassion.
We want them happy and excited to keep on coming every day, like make them feel like we're a team. It's the MCDC family. We're supposed to work together.
MCDC is here for people of all races and all ethnicities, all languages that you speak. We're here to help.
Thank you. So, I want to thank you all for your time, your attention today. I know that you're going to enjoy this wonderful conference and the great speakers that will be presenting today. I certainly enjoyed spending this time with you. On the next slide should be some contact information. So please feel free to reach out to me if you have any questions about either MCDC or anything I discussed with you today. I'm more than happy to also take questions at this time.
Thank you, Dr. Brown. I think we have a few questions. I just wanted to tell you that your story is very inspiring. Beautiful work you've done in the community, and thank you for your service. So I believe we have a couple of questions, Dr. Joaquim.
Yes.
Okay, great.
Thank you, Marisol. Thank you, Dr. Brown. Again, fantastic story. We really appreciate you being with us today and sharing that wonderful story. I did note your humility in saying that you didn't have formal training in DE&I, in the spirit of all of us always learning from each other. But I would venture to say that those who do get training probably are getting it in hopes of knowing probably half of what you already know. So with that, I would like to go to the Q&A and see what questions we have there. One of the questions is, I work for the State Office of Rural Health in Texas. We are in dire need of dental care in most rural communities. How do you recruit and retain dentists?
Well, one of the things that we've tried is to partner with the local communities. So one of our locations in Hillsdale, Michigan, very rural, we partnered with the county hospital there. We tried to partner with some of the social service organizations in actually putting in financial incentive together, a package to get a dentist to come to that community. So it was all of us really working together to try to recruit someone there. And we finally, after being closed for about a year, were able to reopen. We have a dentist there now.
The other questions are so far all just thanking you for a wonderful presentation and for your wonderful work that you do and you have done, and for sharing your story. So while I wait to see if any other questions come in, I have a question for you that I think you're uniquely qualified to answer. One of the most impactful experiences for me in a rural hospital emergency room was seeing a young 13-year-old teenager who was recently kicked out, by her family for coming out. So do you have any advice as a CEO, as somebody who thinks about costs, or just any thing you'd like to share about the cost aspect, to the individual and to the community when something like that happens?
So do you mean they were kicked out of their home, you're saying?
Yes, a 13-year-old.
Yeah, and you still see that a lot. Like I said in my presentation, although things have gotten better, you still see a lot of homeless teenagers because they came out to their parents and their parents made them leave. There are a lot more social organizations now and drop-in centers, and I really applaud those people that open those types of places that kids can go and be themselves. They can get a hot meal. They can get a shower. They can wash their clothes. There needs to be more of those types of places, these drop-in centers for children like that.
Well, thank you again for sharing your knowledge and your time and for telling us some wonderful story. And everything coming in is just people thanking you, no questions. So.
Well, I like to thank everyone. I saw all of the chats coming through, and I'm really grateful to have had this opportunity. I appreciate it.
Great.
Thank you.
Marisol, I turn it over back to you. Thank you, Dr. Brown.
Again, thank you, Dr. Brown and Dr. Joachim. So we have several presentations this morning, and once the morning session is complete, attendees will be able to analyze data and utilize an evidence-based approach to achieve better oral health outcomes, explain the impact of health inequity on oral health in rural communities, identify challenges and barriers affecting oral health in rural communities, recognize the impact of COVID-19 on access to oral health in a post-pandemic era, and predict future oral health trends relating to the rural landscape. So it is a pleasure to introduce Dr. Nashon Hornsby, Assistant Commissioner at the New Jersey Department of Health Community Health Services Division.
There we go. All right, good morning. Good morning, everyone. First, I want to thank Dr. Joachim. I want to thank Dr. Brown for that wonderful kickoff. And I want to make sure that we recognize the great work of individuals, leaders like Dr. Brown. As we talk throughout this day, it's important that we understand that rural health is critically important to overall health of a state. And so if we're not looking at rural communities, but also as Dr. Brown talked about vulnerable populations within a subset and looking at specific groups within an already vulnerable population, you see that there could be huge disparities in access to care. So with that, I am Nashon Hornsby, Assistant Commissioner of the Division of Community Health Services here at the New Jersey Department of Health, and it is always my honor to collaborate with our friends at Zufall Health to discuss issues related to reaching the most at-need populations within our state. And so I'm going to focus right now on COVID-19 and rural health in New Jersey. If you'll advance the slide for me, thank you. So where are we when we're talking about rural New Jersey? First, it's important to note that the Federal Office of Rural Health Policy indicates that all non-metro areas, when you look at the rural urban commuting area codes, that is, really one of the ways that we're depicting rural. In New Jersey, we have a specific definition of less than 500 people per square mile that we apply to determining the more rural areas of the state. Everyone knows that New Jersey is the most densely populated state in the country. And so folks would not typically think of rural when they think of New Jersey, but we've got to also remember that we are the Garden State. We do have still a great number of areas of the state where we have large open farm land that is still being operated. We also do have, within the same county, we could have some of our, more densely populated cities. And so the unique nature of New Jersey is that within our small footprint, we have a very diverse landscape. So within our counties, 21 of them, there are 7. that we consider rural Atlantic, Cape May, Cumberland, Hunterdon, Salem, Sussex, and Warren. And then there are sub-counties or portions of counties, Burlington, Gloucester, Ocean, Monmouth, and Morris, that also have rural tracts. Next slide. Now, there is an impact of being in a rural setting, and we all have heard this for quite some time. And it's important to note that there are higher rates of heart disease within rural settings, cancer incidence, diabetes prevalence, asthma prevalence, and hospitalization related to asthma, and finally, a higher proportion of the population that is overweight or obese. And as we all know, obesity is a significant risk factor for a number of health conditions. Next slide. There is a specific population that I do want to talk about within the rural setting. That is our migrant and seasonal farm worker population. There are approximately 875 farms in the state. Again, we're a very densely populated state, but we can squeeze so much into our state as far as farms, and we do. We are known very well for certain crops, including our cranberries, blueberries, our tomatoes. And so New Jersey is still very much considered the garden state in this sense, and we do export out of our state a lot of those crops. Also, if you ask certain folks that Jersey corn, sweet corn during the summer is one of the things that people actually prefer as well. So our migrant seasonal farm workers are a high-risk population, and much of it is due to a number of factors. Their transitory nature. Some of them, many of them, if not most of them, are not, don't have the most secure status within the United States, and as a result, do not have health insurance. And so there's a lot that's going on there. We also learned during COVID that because of the nature of seasonal farm workers, they have congregate housing typically when it's harvesting season. In other words, they're living in a shared space with others. And then there were challenges when we were trying to address COVID in assessing vaccination coverage and accessing providers for that population. Next slide. So what did we see relative to COVID-19 in rural areas? And now this is national data. As you can see, the red line is rural, and you see it's higher than the blue line, which is metropolitan. And its rates expressed in 100,000 per week deaths. And so you can see that all of the statements that were made early on that that COVID was really only spreading in metropolitan areas is truly false. But also the death rate is worse within the rural setting, contrary to misstatements that had been being made for quite some time. Next slide. So this slide depicts the differences in vaccination based on rural versus non-rural counties in New Jersey. So we referenced the 7 rural counties and then the others non-rural. And you can see that from the yellow dots, the vaccination rates are in many instances lower within those rural counties as compared to the non-rural. Not in every instance, but in a couple of those you can see. I'm glad to announce that New Jersey specifically has had, a higher than national average vaccination rate across the state. And so we are trying to buck against the pattern. And part of the reason why you see such close approximation with our rural counties versus non-rural in New Jersey is because we had established vulnerable populations task forces. And Dr. Taiwo, who's the director of the Office of Primary Care and Rural Health, who you'll hear from, she actually worked a lot with the migrant farm worker population, also with meat processors and others within rural settings. And so that's why you see a great parity as much as we could in rural versus non-rural. I would dare say that in some places you would see a very different picture. Next slide. So the COVID-19 cumulative case rate per 100,000, you can see the various lines, and the purple is the large central metro. The green is the large fringe metro, the medium is metro, and then the small, the medium metro, and then the reddish color is the small metro. And so as you can see, there are different levels of case transmission within those different categories, but they all had been going up. And as you can see, right now we're in a season where the rates are going up across New Jersey. Next slide. Now the death rate, sadly, is also something that we are seeing the cumulative. Now this is cumulative, so it's not that it's showing, you know, things as they are, as if they're increasing at the current time. It's showing a cumulative. So at the end of that bend, you see that it's sort of flattening out. And that's because our increases in deaths in New Jersey have dramatically been leveling. And so we're getting somewhere in the, you know, dozen deaths a day, as opposed to hundreds of deaths, which we were seeing back when you look at the steep incline from 2020 to January through July. You see that steep incline in that period. New Jersey has been able to effectively get a significant proportion of our population, 93 or so % of our population has had at least one dose of vaccine. And that's why you see sort of a leveling off of the cumulative death rate from the area between the December 1, 2021 and October of 2022. Since we've had vaccines readily available now to all populations, you're seeing that advance, that curve sort of flatten out. And so that's really giving you a sense of how we have done in New Jersey relative to COVID-19. And we are hoping that our continued efforts to look at all populations of New Jersey, but with an eye specifically in the context of this gathering on rural, that New Jersey's efforts to assemble a team to specifically look at vulnerable populations in rural settings, that they will continue to yield positive results, that it will continue to keep that line flat across New Jersey and keep it flat across those small metro area. You can see that red line there. It's a little, the peak, the trajectory is a little higher than the others, but we're trying to keep it flat as much as possible. So with that, I thank you so much for joining us for this conference. If there is time, I don't know if there is, I can certainly answer questions that may be presented for me at this time. And thank you.
Thank you, Dr. Hornsby. So our rural counties in New Jersey definitely face these socioeconomic challenges. So here at the New Jersey Department of Health are working on different initiatives to tackle those challenges. So I'm going to pass it on to Dr. Joachim. I believe Dr. Joachim, I'm not sure if you have a question for Dr. Hornsby. Okay, so no questions at this time. So thank you again. Dr. Joachim, I see you there. Okay.
Yes. I think we were going to encourage the participants to chat in their questions at this time, and we'll take questions at the end, if that's okay.
Sounds good. Thank you.
Thank you.
Very good. Thank you. So I would like to introduce Dr. Darwin Hayes, our Dental Director at the New Jersey Department of Health, Community Health Services Division.
Good morning. Can you hear me?
Yes.
Thank you. Thank you. Awesome. Well, good morning. I'm Dr. Darwin Hayes, State Dental Director for the Department of Health. I want to share with you an update on some efforts to increase and also promote access to quality oral health here in rural New Jersey. We'll talk a little bit, some background information, update you on some current activities, and then share with you some activities as we look into the future of rural oral health here in New Jersey. So rural oral health matters because you're not healthy without good oral health. We have talked about this every year in this conference, and also during the time in between the conferences, of the importance of oral health and its connections to health itself. We also know that health includes oral health care related to all the different connections with the heart and lungs and other chronic diseases that are related to oral health as well. So we here in New Jersey have a very strong community of oral health leaders and partners and collaborators that are all working very hard and continue to work very hard to represent oral health, but also to share why and how oral health is definitely a part of overall health. And that's a theme that we want to continue not only for this conference, but also moving forward. So a little background about New Jersey. New Jersey is one of the states that we have less than 16% of the residents have fluoridated water accessibility. Still having some challenges with provider recruitment in both the dental health professions shortage areas, and then also at the FQHCs. We also know in rural New Jersey, there are some challenges with regards to travel times and getting to care, and that there are also lower reimbursement rates for those zip codes and those communities in rural New Jersey. Back in 2015, Rutgers School of Social Work provided a rural health needs assessment. And of course, tooth decay and poor oral health were a major issue. In addition to that, consumers also felt that dental care accessibility was second to affordability, but it was a concern for many consumers, for many residents, and also noted that dental care was the #1 requested specialty service. Some facts about rural New Jersey as well, as Nashon shared with us the complexity of how New Jersey is designated and and how it's named with regards to rural counties. We know that about 60% of the state is comprised of rural areas, quote unquote, rural areas. And another statistic related to population is that close to 95% of the population live in areas, 40% of the areas that are designated as urban areas. So even though less than 10% of the population in New Jersey are in rural areas, it's still a concern for many residents related to access to care and oral health as well. And then we also know about rural health related to the zip code, right? The zip code still being a stronger predictor of oral health outcomes more than one's genetic disposition. However, and fortunately for us here in New Jersey, we've got some amazing fairly qualified health centers that operate and serve populations in rural areas, and they continue to do some amazing work with oral health. So we want to say thank you not only to all of them throughout the state, but those specifically listed here that are in some of the rural counties: Complete Care, Ocean Health Initiatives, HMED or Lakewood Resource Referral Center, Monmouth Medical Center, Visiting Nurse Association of Central Jersey, Southern Jersey Family Medical Centers, and also Zufall Health Center. So again, we applaud you and appreciate the ongoing efforts and the amazing work that you're doing here within our state. Currently, we have some programs here in New Jersey. The Children's Oral Health Program is New Jersey's longest existing oral health program, over 35 years. And one of the deliverables that our program executes every 2 years is a Dollar Smile Dental Directory. This directory identifies access points for residents to reach oral health services throughout the state of New Jersey, and it's listed by county. So it's a great resource, and that allows individuals to get to oral health. In addition to that resource for all residents, we are currently engaged in a basic screening survey. Many of you may have heard of it before, but the Basic Screening Survey, or BSS, is the Centers for Disease Control and Prevention recognized evidence-based oral health surveillance tool that gathers data regarding the health status of third graders. And that's been our focus for this first attempt at doing a BSS in New Jersey. We have partnered with our Children's Oral Health Program and also with the Association of State and Territorial Dental Directors to launch, again, New Jersey's first BSS surveillance survey. We've selected over 30 schools, elementary schools, that were, again, randomly selected. And overall, the goal of the initiative is to improve student attendance, but also oral health outcomes. And it's really important to note that this survey is important for New Jersey. If you look here on the screen in this red arrow here, you can see Jersey is in gray, and New Jersey is one of several states that have not provided any oral health data to the portal related to the percentage of students with untreated tooth decay for third graders. So it's a big initiative that we've undertaken, and currently we have 26 of the 30 schools that have been completed, and we are looking to complete all the rest of the activity by the end of the year, and then moving into the first quarter of 23, we will be analyzing and submitting that data to the CDC for the first time. So really excited about this initiative. Other initiatives that we've also have had some success with. Back in 2018, we were awarded the Oral Health Services Unit's first 4-year HRSA grant, State Oral Health Workforce Grant, and had success in 4 areas. Number one, being able to bring on a state dental director for the first time in 30 years. Second, we had some opiate education and training modules that were designed in collaboration and working with Rowan School of Osteopathic Medicine and also their pain institute to address the opioid epidemic and to share some best practices in writing prescriptions. Third, we had a nutrition counseling and obesity control program that was implemented in a restructured dental visit. And that included screening children for BMI, checking to see who were, which of those students ages 6 through 11 were obese or were overweight. We also checked caries, and then also we had food education, and we implemented a first ever food delivery program to address not only food insecurity, but also giving patients and their families direct examples of what healthy food looks like, tastes like, how to prepare it, et cetera. And then our last activity is the state oral health plan that we were able to get some work within this 4-year grant. So a lot of activities for during the 4 years that I've taken on, that we've taken on with a little over $1 million of grant activity. So what's next? Moving forward into these next couple of years. Well, we know when we move forward and we look at all how densely compacted our state is and the ranges of care from north to south, we know we need action, we need changes, we need things to happen to move forward. And we have to move forward with the notion that we want to make sure that the mouth stays connected to the rest of the body with all of our health policies and programs. So how do we get more policies and programs? Well, we do that by having a strategic plan. And I've shared with you, most of everyone over the last 2 years, our work in developing New Jersey's first state oral health plan. It is going to be a living document of high aspirations and priorities and objectives. And this started back in June of 2020. And we have completed the second phase back in the fall of 2021 and into earlier this year, where we reviewed all of our final narratives and components from our advisory group of stakeholders. Over 30 people graciously volunteered their time. And currently the plan is under final review by the commissioner's office. And then it would also be going to the governor's office for input. So very excited about having this plan released, and some of the focal priority areas to be addressed in the plan include access to care, medical dental integration, state funding that's allocated directly for oral health, and then also a very important priority related to oral health equity and culturally competent practices as well. Also, some moving forward, many of you have heard of the success that Zufall has had as being the first FQHC in the nation to implement, host, and graduate the first class of community dental health coordinators. Very important initiative, especially as we continue to look at ways to connect patients to health through oral health, but also in addressing workforce challenges We know that the community dental health coordinators have a unique niche in being able to stage and actually provide some community health interventions that really increase awareness of health conditions, leading to positive healthcare decision-making, but also leading to positive health outcomes. So this is another success here, here in New Jersey that will continue. Also, in that, there is some new development related to having dental training programs that also Zufall is recently awarded a grant from HRSA to look at being an opportunity to train and to teach and specifically do those trainings in these rural areas. This is a teaching health center program, and most of the training sites, as indicated here, are in medically underserved communities, and training in these communities, again, increases health services and it adds more primary care workers, all of which are challenges for us here in New Jersey in the recent years as well. Also upcoming is our second HRSA grant. We wrote a grant back, an application back in January this past year, and found out most recently that we were awarded a new 4-year HRSA grant that will be addressing caries prevention through risk assessments, dental sealants, and nutrition education and counseling. Again, nearly $2 million over the 4 years to for us to implement and gather data within a statewide intervention to improve caries prevention efforts using, again, risk assessments, dental sealants, and nutritional counseling. We want to make sure that we are make sure that we are increasing access to low-cost preventative oral health so that we stave off more costly treatment in the future and even more of the emergency care that gets rendered. To improve oral health for our at-risk populations, and then also to increase the awareness and understanding of the various nutritional related linkages that can be harmful, but also those that can be complementary to achieving oral health. We're looking to have this released later this year, with the first set of providers starting in the first quarter of 2023. And then quickly, just want to round off some of the other items that we're working on that we will continue to work on. I mentioned the basic screening survey. We're looking to submit that information to the CDC for the first time. Also, we want to continue to focus on areas like chronic disease and those connections that those diseases have with oral health, namely diabetes. Also working with workforce options, which I know will be discussed later today. Also issues with transportation, telehealth. We know telehealth is a mechanism that can be used throughout the state. Also focusing on taking and bringing oral health care to the home or to where our residents in rural communities are located through mobile vans as well. Also, we want to continue to look at best practices, come up with some innovative interventions, and working with interprofessional teams, coordinated care, and also programs related to oral health champions. We're looking to partner up with the 1 Million Mouths campaign through Harvard University and CareQuest, so that we can create some oral health champions so that we can address and get more access to care, but also get more access to individuals that need care as well. Also looking at a pilot program where we're going to be combining and looking at smoking and tobacco usage and having an enhanced visual oral cancer screening and doing some referral services to New Jersey's quit centers and also FQHCs as well. And then again, all of this can't be done unless we continue to collaborate together, not only within oral health, but within healthcare across the board as well. So in closing, I just want to say that, you know, our dental oral health community here in New Jersey continues to be strong, and we want to use the momentum that we have to put all the pieces together and be able to move forward in a positive way, but in a positive way that improves outcomes, improves health outcomes. So enjoy today's remaining presentations and also be willing to contribute now, because we need you now. Thank you.
Thank you, Dr. Hayes. Just wanted to remind you that we'll answer your questions after the next presentation. So please continue to submit your questions via the Q&A window, and we'll get to those questions after the next presentation. So it is a pleasure to introduce Dr. Lola Taiwo, our Executive Director at the New Jersey Department of Health, Office of Primary Care and Rural Health. Dr. Taiwo.
Marisol, I don't know if Dr. Hayes is still with us while we wait for Dr. Taiwo, but maybe you could answer a question for us, Marisol or Dr. Hayes. But I see something in the chat from Kathy Johnston, who was wondering if it's possible to share some of the resources with the folks in Texas. She is the Texas Region Coordinator, and she would love to connect with Dr. Hayes, I believe, to get some of those resources. So Marisol, I guess that's a question for you. If we could make that connection, it would be great.
Absolutely, yes. So we can even, get those resources, so we can actually schedule a meeting and go over, how we can collaborate and support. So absolutely, yes.
That's great. It's wonderful. Offices of Rural Health to connect with each other throughout the country. A lot to be learned from each other. Right. All right. I think we're waiting for Dr. Taiwo.
Is this better?
Yes.
Okay.
Okay, good.
Okay, so now I'm going to share my screen. Can I share now?
Yes, you are fine now.
Okay. All right. Share. Can you see? Can you see my screen?
Yes.
Okay, perfect. All right. And let me, sorry. Trying to make sure that this is the slideshow. Okay. Hi, sorry for the technical difficulties. So my name is Dr. Taiwo, and I'm in the Office of Primary Care and Rural Health and within the Department of Health, particularly within the Division for Community Health Services. So we're going to go over identifying and addressing oral healthcare workforce shortage areas or shortages in rural areas. So just to kind of give you a little overview of the Office of Primary Care and Rural Health, so we essentially have 4 different programs. Our primary care office really looks to identify statewide needs, primary care needs, identify shortage designations. We work on health professional recruitment and engagement, and then just conducting technical assistance and providing, what technical assistance that we can. Our State Office of Rural Health, our responsibility within that unit is to collect and disseminate information, identify rural health needs, really coordinate and collaborate rural health activities to make sure that we're maximizing resources and provide technical assistance. Our other kind of core program is our Uncompensated Care Fund. And so we, through the subsidy fund, we reimburse federally qualified health centers for providing primary dental and mental health care for the uninsured and underinsured individuals, residents in New Jersey. So that's often low income and undocumented. And then due to the pandemic, we have a series of CDC grants that really enable us to ensure that healthcare providers can provide equitable access to testing and vaccinations. So as I said, we were going to get into kind of the data. So understanding, where areas across Jersey have shortages and what are the resources that are available to help address some of those shortages. So when we, are looking at what a shortage means or what a shortage is, that's often anchored on dentist patient to population ratios. And so the federal government essentially says that every place needs at least 5,000 to 1 provider. So 5,000 people to 1 dentist, right? But, as we know, that's quite a large number. And so ideally, we would like to make sure that we really have enough providers, enough dentists in particular, who are able to care for the populations that are in need. So when we're looking at, particularly our rural counties in New Jersey, as you can see, there are some counties that are doing, great. They have an adequate amount of providers based on their population. And so Morris and Monmouth would probably fall into those spaces. But then you have other areas within our rural communities like Salem County, where we have, nearly 3,000 patients to 1 provider. And so that really helps us understand, okay, there is a shortage in this area, and we really need to ensure that the state and the federal government understands that so that we can start to recruit for providers. And so this just kind of also goes over some of our medically underserved areas. So when I say medically underserved area, essentially that would be a geographic area that there are not enough dentist providers or not enough dental practices. And so that in itself makes it a shortage area. And so as you can see here, Atlantic County has, 26 municipalities that would be considered medically underserved areas. Middlesex has quite a bit. Cumberland also has about 21. And then as you can see, Essex County, they have 63. And so what essentially that means is that because there's such a large population in those areas, there's just not enough providers to service the entire population. So this kind of goes over some of the other issues that are going on in Jersey. And so as you can see, there are, as I mentioned, there's either a disparity in the demographics or there's an excess distance. And so there's just a wide, large space between where providers are located. And so if you can see where the Warren Morris County is, there are 170 residents, and there are no providers within that 1 catchment area. And so that would essentially say that there's excessive distance and that we need to increase the providers that are in that area or increase the practices that are in that area so that these patients would be able to drive to a location that is somewhat near to them. And if you can look at Dover, So the populations also change, right? And so Morris, when we're looking at Warren Morris, the Caucasian and the white populations are higher. And so the need, demographic need is different. And then when you're looking at Dover, which is all, still within the same Morris County population, the Morris County area, the population of need are often the Hispanic population. So you can see 64%. And so rural really comes with a wide array of different demographics. And so it's really important to understand the local issues that are happening so that we can address them accordingly.
I'm sorry to interrupt, Dr. Taiwo, but
yes?
There's a request to change your settings to the slides. We see them small, and we could see the next slide. That's coming up.
Okay. Sorry. I don't know how to fix that part. Is that any better?
Dr. Taiwo, I think if you do the slideshow and remove the slides on the side, that will make it bigger.
Okay, 1 second. I'm having all sorts of technical difficulties there.
Dr. Taiwo, if you just press the on the bottom near the purple of your slide, right next to the book on the right, you'll see like a little, almost like a screen on the bottom.
On the bottom here?
Yeah, go to the right.
Okay.
All next to the minus button to make the screen smaller.
Sorry,
in your PowerPoint?
Yes.
Next to the yeah, the one on the left. Nope, the one on the left. Right there, that one. Yes.
Yes. That better? Are you able to see that now?
Change display settings. Right there on the top where it says display settings.
Okay. I don't know why we're having so much difficulties today. Okay. Why is this happening?
Is anything popping up?
Swap presenter, is that what you're looking for?
Yes.
Is that better?
There we go. Perfect. Thank you.
Okay. All right. Let's get back into the swing of things. So are you able to see just one slide? Or are you seeing both?
We're good. We see the one slide.
Okay.
Perfect.
Okay, perfect. Okay, so this is just an example of how we are looking to expand our HPSA designations to make sure that there are geographic HPSAs. So I'll get into this a little bit later, but New Jersey really has auto HPSA. So our federally qualified health centers like Zufall are automatically eligible to become national health center sites. And so we're currently working to see if we can expand that and let the federal government as well as the state know that there might be full counties that are in need of providers. And so these are kind of this is just an example of what that looks like. And so right now we're working on Cape May County. So as I had mentioned before, there are different resources, incentives that we work with our HRSA partners to help recruit providers. And so once we have a HPSA site, which is a health services or health professional shortage areas, that essentially, as I mentioned, tells the government that, hey, there's areas where we don't have enough providers and we really need different federal and state programs to help recruit them. And so some of the programs that are available are the National Health Service Core Loan Repayment Program, which requires 2 years of commitment by a dentist or a healthcare professional. We have the Student to Service Loan Repayment Program, which requires 3 years of commitment to work in an underserved or rural area. And then we have the National Health Service Core Scholarship, which requires 2 years to work in a underserved or an underserved area. Another platform that we use to really help recruit is to use 3RNet. So 3RNet is what I consider to be the Indeed for underserved and rural regions. It's really a platform that enables healthcare facilities to advertise their job vacancies. It's free of charge. New Jersey pays a membership to be a part of this, and then all healthcare providers within Jersey can use it. And then this is a national database. So you're able to post a job, you know, in Dover, New Jersey, and folks from all over the country can look at it. And so let's say people are looking to move to the East Coast, move to New Jersey, move to New York. This is a resource that they can use to look for those positions. So this kind of goes over some of the details, and we have a wonderful staff member, Brianna Folks, who works to manage this website. And so if you have any questions, please feel free to reach out and we'll be happy to set you up. As I mentioned, this is of no cost to the health facility, but it's really a way for us to get the need out there and to ensure that regardless of where people are located, they can look for jobs in areas that they would like to, in underserved areas. There are multiple resources. So once you go on their 3RNet website, which I'll be happy to show you, there's, you know, their Twitter pages and their LinkedIn. There's a series of articles and then other resources that they utilize just to help people get more comfortable with utilizing this in their recruitment efforts. And so this is just an example of how useful this website can be. And so between, you know, October 2019 to 2020, and this is, you know, in the height of pandemic when, you know, a lot of our healthcare workforce were being hit severely, we were still able to recruit, you know, nearly 1,300 physicians and nearly 300 nurse practitioners and 124 dentists solely by using this platform. And so I do think it's really important to ensure that people are aware of these resources and utilizing them. And I'm you know, honing on this because right now Jersey only has 8 active New Jersey healthcare facilities, and we definitely have more than 8 facilities that are in rural and underserved areas. So we are not utilizing this half as much as we should. But as we've had Brianna join our team, and she's been with our team for, you know, a little bit less than a year, we've really managed to increase the views that are coming to our page. So you can see in January, we started at, you know, 1,900, a little over 1,900. And by October, we were, you know, kind of pushing almost 8,000. And so as we start utilizing these resources more, we really have the opportunity to recruit people to come to Jersey. And quite frankly, I think Jersey is pretty cool. I mean, Arkansas and Oklahoma and all these other states are wonderful too, but Jersey is pretty cool. So the registration process is pretty simple. You complete a employer registration form. You'll get an email that's verifying your account, and then you can begin posting career opportunities. So it's a fairly straightforward process, and I implore every person who's on this webinar or on this conference today to really join 3RNet and start utilizing it. This is just an example of some sites that are using it. So it's CamCare. In Camden, they're, you know, advertising for pretty much everything under the sun. And this is not just for healthcare professionals. Let's say you're looking for a CFO or you're looking for medical billing. You can also post those positions on here as well. So here is the website. I'm just going to leave that up there for a little while. As I mentioned, you can email myself, you can email anyone in our team, Dr. Hayes or Nashon and Brianna Folks, in order to get any more information about this program. But it is a wonderful free of charge program that I really, and I will continue to say, implore people to use. So along with our 3RNet program, another incentive is a J-1 visa, Conrad 30 waiver program. So this really allows foreign medical graduates who would normally have to go back to their home country, if they, you know, choose to work in an underserved area, they can apply for this visa and they can, you know, work in those areas. And so, yeah, we've had this program for years. Our office is the one that manages it. Our staff are pretty diligent in reviewing the J-1 visa applications and processing them as soon as we can. So within a month, they get reviewed and they sent up to our legal department and our commissioner. Once our office is done reviewing them and the Department of Health is done reviewing them, then that gets sent to the Department of Homeland Security, and they are then able to either accept our recommendation, which they typically do, or reject it. And so some interesting facts. We have 30 slots available. We have I can't recall if we've ever filled all 30. So I'm also employing folks to utilize these resources. 10 out of our 30 slots are for flex slots. And so that means that, let's say your health facility, you're not an FQHC, or your health facility is not located within a MUA, which is a medically underserved area, or an MUP, which is a medically underserved population. You can still apply for the J1 visa, but you just have to show that you are still servicing the percentage of patients that are in those areas. So you're still servicing the underserved populations. And essentially you need this is a 3-year contract. You have to work a minimum of 40 hours clinically. So this does not mean that you're doing, faculty or any other services, and just have to be, with a New Jersey medical license and board eligibility. And so, this is perfect timing because our season has just begun. So far, we have 1 application that is pending and 29 more to go. And funny fact is, New Jersey has never had any dental providers apply for the J1 visas, and they can. This isn't a program that's open to everyone. And so once again, I am imploring our health facilities to utilize these resources as a way to recruit. So I had mentioned our loan repayment programs, and so I'm just going to go into that a little bit. So our New Jersey operates with auto HIPSAs currently, and so that means that all of our federally qualified health centers like Zufall, federally qualified lookalikes, our federal prisons, immigration and custom enforcement facilities, they are all eligible to apply for the national programs. Any facility that is not part of those FQHCs and are in a medically underserved area, they can apply for our state loan repayment program. And so this kind of goes over the scoring process. So as I mentioned, HRSA looks at a patient to provider ratio, but they also look at whether or not there's fluoride in our water. They look at a series of other criteria just to kind of determine what that overarching score is. And so their overarching scores typically are from 0 to 26. 26 means that there's a high need and 0 means that there's a low need, but each program has a different requirement. So for example, our loan repayment program, it looks at all scores from 0 to 26. So essentially all dental providers who are in a eligible site like Zufall would be able to apply for that. Our scholarship program, the NHSC scholarship program, now that criteria is a little bit more competitive, and so it looks at scores from 18 to 26. So a lot of our rural sites are not actually eligible for that particular one because their scores are not high enough. And that essentially just means that there's enough providers, but not as much as we would like them there to be. And the same with our National Health Service student program. So that looks at scores that are from 14 to 26. And so all of our rural FQHCs are eligible for that program. So the scores do matter, but I don't want to, especially at a time like now, when we've had enough, where the federal government has more funding, they've been more open to giving more scholarships. There are years when funding is a bit low and they have to be a lot more competitive, but this year we're pretty open. So I really implore all eligible sites to apply for these programs. Okay, and that's essentially my presentation. I know we're waiting for questions after all of this is done, but once again, if you have any questions, please reach out. I want to make sure that everybody's comfortable with these programs, and if they have any concerns about, what the application process looks like, or if maybe, they're uncertain about what their scores are, they can always reach out to us and we'll be happy to help them. Thank you.
Thank you, Dr. Taiwo. There are a couple of questions. I think we may be able to answer just one of them. So one of the questions is, New Jersey is also struggling with recruiting and maintaining all types of healthcare professionals, including dentists. What is the New Jersey Department of Health doing in reference to this issue?
Sure, I can answer. So similar to what I was presenting. So, and I don't think we really went into our state loan repayment programs, but along with our dental program, our national programs, we have state loan repayment programs. And so we're really pushing and promoting folks to utilize a lot of these resources. The shortage designations that our office conducts is really the first step. So essentially it says, as I mentioned earlier, it's an alert to both the state and the federal government that there are areas that, we really need assistance. We're not getting enough. And so we need those shortage designations to be in place in order for that to happen. Once that happens, then we are really open to all of the incentives that I'd mentioned. So the J-1 visas, ensuring that people are, really promoting their vacancies as much as possible. A lot of times our health centers, their salaries are not, or might not be the same thing as a salary for a larger health facility. And so there are other things that we can promote, right? So you're promoting the culture of your organization. There are lots of mental health programs that we're looking at for our providers, because there has been quite a bit of, COVID really took a hit on a lot of our populations, or a lot of our health professional populations. And so understanding that and really addressing the mental health needs of our professionals is critical to maintaining and recruiting a workforce. And so these are some of the incentives and tips that we are working with our healthcare facilities to utilize so that they are able to recruit as many professionals as humanly possible.
Thank you. I think we have time for one more question. Have you used the J-1 visa program for a dental hygienist?
So no, the J-1 visa program currently is for medical graduates. We are looking to see if that definition can be expanded, but currently it is for medical graduates.
Very good. Thank you, Dr. Taiwo. So I think this concludes our DOH presentations. So we're going to move to a 10-minute break, and we'll see you shortly. Thank you.
Thank you.
Welcome back, everyone. Hope you were able to stretch your legs a little bit. So we're going to continue with our morning presentations. I would like to introduce Dr. Michael Monopoli, Vice President at CareQuest Institute for Oral Health.
Thank you, and good morning, everyone. I think my slides will be shared in a minute. I'm really happy and honored to be a part of the panel this morning. It's been a really interesting morning with a lot of really interesting presentations. And I think that I'm also looking forward to being followed by Dr. Chalmers and Alan Morgan and Zil Dixon Joyce Romero to round out more of the information that is possible to present. Share my slides. What I'd like to do this morning while we're, oh, there we go, great, is to, in the context of a funder and advocate, to put some information into the group around using a rural lens to address diversity, equity, and inclusion. And I'd like to do that first by starting with a brief overview of the organization that I am a part of, which is CareQuest Institute for Oral Health. As you heard, I'm Michael Monopoli. My pronouns are he, him, his, and I'm the Vice President for Grant Strategy. And in the context of CareQuest Institute as a potential partner and resource and support for all of you and for all of the work that you do going forward, I just wanted to spend a little time doing that description of CareQuest Institute, but also to start to think about what are some of the key issues or key things to think about when we're thinking about diversity, equity, and inclusion with a rural lens. So next slide, please. And as you heard already this morning, oral health is an essential component of health, and our goal in working with all of you, and we have a shared goal, is to really work to create a future where every person can reach their full potential through optimal health, and optimal health includes optimal oral health. Next slide. And I think if you've heard about us in the past, we've gone through multiple iterations of names over the past few years. So I just wanted to put a slide to show that formerly we were a funder as a DentaQuest Foundation and a research and data analytics group as a DentaQuest Institute, which merged to form the DentaQuest Partnership for Oral Health, still the same organization, just with a different name and a bit of a different structure. And now we're CareQuest Institute for Oral Health. And CareQuest Institute for Oral Health is focused on transforming the oral health delivery system. Next slide. And that transformation is bringing us to a point where we create an oral health delivery system that is more accessible, more equitable, and more integrated into the healthcare system for everyone. And we do that through 5 areas of activation and 2 areas of influence. Next slide. Part of what we do as in our 5 areas of activation is to be a grant maker. And we believe we're the largest private funder focused specifically on oral health, and always are interested in and welcome outreach to have a discussion about ways that we potentially could fund and help to provide resources for you to do the important work that you do. We also have health improvement programs where we pilot and test strategies to promote equitable access to care. We've been stepping up our capacity to do policy and advocacy, and that's something that I've been involved with and will lead into the future. And we also have a strong data analytics team that provides information for advocates and for planners in general to again, promote oral health, and we have developed and we are continuing to build an education program that is web-based and provides information for community partners and professionals going forward. And one of the things that we have been focusing on is to support rural health, support oral health in rural areas, and to support improved quality of life. Slide. And in that work, we have a relationship with Delta Dental of Massachusetts, is a dental benefits company to help us to provide information and support. And we have been developing an innovation center that looks specifically for innovations that promote prevention and promote improvement of health for underserved populations. And most of the work that we do around that, there has to be a short-term show of improvement of either access or oral health in underserved populations. So next slide. So thanks for indulging me in that. I just wanted to make sure that if anyone has any interest in furthering conversations, you can definitely reach out to me and we can continue to do that. But first, in terms of thinking about DEI, I just wanted to put some definitions on the table for everyone to think about. And there are multiple definitions for all the components of DEI. But I think the most important components of that are diversity, and we really need to be mindful of the differences that can cause disadvantages or barriers to care. And that one of the most important components of focusing on diversity is to look at and address some of those issues that create those barriers. And really, again, there's multiple definitions of what equity is, but I think what I'd like to just reduce it to is that equity is fairness and a distinct possibility and a focus on reducing unbalanced conditions so that we can reach a more fair place where we can provide equal opportunities to all groups. And I'm sure all of you have seen some depictions of equity. One is an apple tree and different population individuals underneath reaching up to reach an apple. And the description there is that there are different levels of boxes to get people to the point where they can reach the apples. And there's another one of a fence and people looking over the fence at an event. Actually, if you can go back. Thanks. Looking at that event and that, again, there's different size boxes, so different strategies to address the barriers that each of those populations face so that they all can look over the fence. But I think that one is a great way to think about once you've addressed those areas, and the next thing is to think about how do we remove the fence. And that inclusion is really about feeling belonging. And I think there's particular strength in rural areas to really focus on inclusion because there seems to be more of a sense of connectedness in rural areas, and that just intentionality about extending that connectedness to diverse populations is something that is doable. Next slide. I think when you're addressing DEI, it's really important to have a clear statement of this is what we are doing to promote diversity, equity, and inclusion in our community and our organization, and to develop a plan, but to develop a plan that is specific to your community and one that is doable. These are areas that take some time to help to develop, and I think that to have a set of specific outcomes that you're looking for that are doable and that you can start to see the achievement of those outcomes is important. And some organizations have the ability to have staff that's dedicated to DEI. But if that's not the case in smaller organizations, there's it's important to engage all of the group in what are the things that we can do to plan to address and address DEI going forward. And I think it's really important, especially in rural communities, that one size doesn't fit all, that it really needs to be, and sorry for the typo there, that should be diversity needs to be based on community demographics, and that when you're setting goals for diversity, that it really needs to be very specific to your community, and that that community resources and infrastructure can all work together to help to develop equity, and that that feeling of belonging and that sense of belonging for inclusion can really be achieved by engaging the broad community going forward. Next slide. So I think that the important component of that is I have some maps here from the Brookings Institute that over the decade of 2010 to 2020, there was really a shift in diversity across the country, and this map describes that shift in diversity. I think there's been a long-standing sense that that rural meant mostly white, but it actually by 2020, 24% of rural populations were people of color. And it's interesting to note on this map that I'm in Massachusetts, which is listed fully as non-rural, and New Jersey is also on the map listed as non-rural. And as we've heard already this morning, that there are rural areas in both of those states, and that we still have we can have a focus and work to help to support movement forward. But if you look at the map, in those light areas, the yellows and the browns, there's been an increase in percentage points of diverse populations, and at the present time, about 3.5 percentage points increase in diversity among rural areas. Next slide. I think what's really clear from these maps is that diversity is highly regionalized. There's variation that's specific to Black populations, Latino and Indigenous Americans. I think that in the past, the rural Black population has been relatively constant, with some movement to rapidly population growth areas. But I think from this map, it's clear that most of the change in diversity has really been largely driven by growth in rural Latino populations, and that growth is expected to continue. And as we go forward, more and more of the country in general, and especially rural areas, will become more diverse, and that we need to make sure that we're focusing on that shift. Next slide. So I think from NOSOR, I adapted these senses of where we should go and what are some of the possibilities around addressing equity, and that addressing equity, as you all I'm sure know, really requires systemic and community-wide change, and a focus specifically on what are the objectives and what potentially could we do to increase equity, and that key rural health organizations really have a role and should be prepared to help to lead and support those efforts. And that part of that is to adopt strategies that improve accessibility and availability and breaks down some of the barriers that people face, and that there are